Welcome back to Nephroma. This video is going to be about anemia and chronic kidney disease. Anemia is one of the major and fairly common complications of chronic kidney disease. As you get to a GFR of 30, the prevalence of anemia goes up to 9%. And once you get to a GFR of 15, the prevalence goes up all the way around to 30 to 50% depending on the study you read. Usually the anemia is hypoproliferative, normochromic, and normocytic. You don't generally have trouble synthesizing hemoglobin, hence the normocytosis and normochromia, as much as you have trouble generating the red blood cells themselves, which is why it's hypoproliferative. Now, patients with CKD are also more predisposed to iron deficiency, so you can still get hypochromia or microcytosis, but classically it's a normochromic, normocytic, hypoproliferative anemia. Now, there's many reasons to get anemia in chronic kidney disease besides the usual kidney can't make erythropoietin reason. But let's go through some physiology behind how erythropoietin or EPO is synthesized in the kidneys. Here I'm going to draw two cells. Both of these cells represent peritubular interstitial fibroblasts. So if this is my renal tubule, the cells are somewhere here in the interstitium. What happens in the normoxic state? That is, what happens when there's enough oxygen going to your tissues? Well, these hypoxia-inducible factor molecules, particularly HIF-alpha, get hydroxylated by something called a prolyl hydroxylase domain enzyme, which I'll label PHD. Once hydroxylated, it also gets ubiquitinated by the von Hippel-Lindau protein, or VHL. Essentially, what that means is that HIF-alpha gets tagged for breakdown by a proteasome. Ubiquitin is basically a marker that tells your proteasome to break down the affected protein. When this happens, HIF-alpha can't act any further, and so you don't get any extra EPO generation in the normoxic state. This is what we expect, and this is what we want. But what happens in the hypoxic state? Well, your PHD enzyme gets inhibited in hypoxic conditions, so HIF-alpha is not hydroxylated. This allows it to combine with HIF-beta and head to the nucleus of the cell. Once there, this HIF dimer binds to the hypoxia response element and upregulates the transcription of erythropoietin. The rest is history. EPO gets generated and goes to the bone marrow to stimulate RBC synthesis. What happens in chronic kidney disease? Well, as your kidneys get damaged, your peritubular fibroblasts get more damaged, and you end up with insufficient expression and function of the HIF proteins. Your fibroblasts can also transform into myofibroblasts that don't make EPO as your CKD progresses. In fact, in chronic kidney disease that is primarily due to a tubulointerstitial disease, your anemia is worse and harder to treat. Why is that? Well, the cells that make EPO are peritubular interstitial fibroblasts, right over here. So if I have a disease primarily affecting the tubulointerstitium, these fibroblasts are going to be front and center in bearing the brunt of that disease. As a result, tubulointerstitial disease results in worse anemia for the same GFR compared to CKD from another cause. There's also other reasons for anemia in CKD: increased hepcidin synthesis from the inflammatory state resulting from CKD, which leads to more iron sequestration and less iron absorption. The uremic milieu also causes earlier breakdown of red blood cells, as in a decreased half-life. And finally, patients with CKD can get secondary hyperparathyroidism due to elevated phosphate and chronically low calcium. If this happens, and if this gets severe enough, bone marrow fibrosis can result, which will prevent your bone marrow from responding to EPO and iron simply because your bone marrow is fibrosed. The mechanism of how this happens is unclear. Now, how do you evaluate and manage anemia in chronic kidney disease? Well, there's a bunch of monitoring and surveillance recommendations that I've listed here. For patients who don't have any anemia, as in normal hemoglobin, normal everything, you monitor them anywhere from every 3 months to every year, depending on how advanced their CKD is. So for a GFR less than 15, you monitor every 3 months. And for a GFR between 30 and 59, so stage 3 CKD, you monitor every year. These monitoring frequencies, by the way, are straight from the 2012 KDIGO guidelines, which is the latest version, unfortunately. For patients who've got anemia, the monitoring frequency understandably is a bit more frequent, anywhere from 3 to 6 months depending on the GFR. And also for patients on an ESA or erythropoiesis stimulating agent, so basically artificial erythropoietin like epoetin or darbepoetin, you check their hemoglobin every 2 to 4 weeks when you start treatment and every 3 months thereafter. In addition, while patients are on an ESA, you check iron stores every 3 months. The idea here is that when you give EPO, that's going to mobilize their iron stores as these patients start to wake up their bone marrow and make more red cells. When this happens, there's a higher likelihood of depleting the iron stores that you weren't utilizing before, and that's why you should check iron stores fairly frequently in these patients. And finally, if they're on iron supplementation but not on an ESA, you again check their iron stores every 3 months just to monitor their response. So now say you have a CKD patient who presents to you with anemia. What do? Well, there's 5 steps to managing these patients. The first is to exclude other causes of anemia. Just because they have CKD doesn't mean their anemia is just from their CKD. If their hemoglobin is 50 or 5 in American units and their GFR is 55, there's probably more to blame than just CKD. One of the big things you have to exclude, which is step 2, is iron deficiency, which you do by getting a ferritin level and iron study, so transferrin, free iron, transferrin saturation, and so on. Now with CKD, the cutoffs for iron deficiency are somewhat higher because there's background inflammation that causes your ferritin to go up, and so if you have iron deficiency, your ferritin might be higher than what you would see in a non-CKD patient. So for non-dialysis patients, the cutoff is a ferritin of 100 and TSAT or transferrin saturation of 20%. If a patient is below these cutoffs, they should receive iron, either oral or IV. Some good oral options include ferrous gluconate, fumarate, or iron polysaccharide. Just make sure the dose is such that the patient receives at least 200 milligrams per day of elemental iron. If you're using IV iron, on the other hand, iron sucrose and ferric gluconate are options with the doses shown over here. There's also other options available, and I'm sure the heme nerds are screeching and yelling those options through their computer screens right now. For dialysis patients, the cutoff changes to a ferritin of 200 instead of 100 to classify true iron deficiency. These patients who are iron deficient should receive IV iron. Oral isn't recommended because iron absorption is significantly worse once you get to dialysis. Now, the KDIGO guidelines are a bit messy. They would actually recommend trying iron supplementation for a ferritin less than 500 and TSAT less than 30%. The cutoffs from up here are for absolute iron deficiency, so the 120 and the 220. But you can still get a relative or functional iron deficiency where your bone marrow can't incorporate the iron floating around into the red blood cells. So your patients with your ferritins between 1 and 500 and TSAT between 20 and 30% might still benefit from a short trial of IV iron. It's worth a shot just to avoid an ESA. So now once you start supplementing iron, you can recheck their iron stores and CBC in 3 months. And there's a few possibilities here. If the iron stores become replete and hemoglobin recovers, great, you're done. But if the iron stores are not replete according to the cutoffs I specified for non-dialysis and dialysis patients in the previous slide, then you either continue the iron or you adjust the regimen. For instance, changing oral to IV, increasing the dose, excluding iron losses, and so on. And finally, if your iron stores are replete but your hemoglobin is still low, that's when you consider an ESA. And that's our step 4. We start an ESA if the hemoglobin drops below 10 despite adequate iron stores and no other causes of anemia present. Darbepoetin alpha at the dose I've written or epoetin alpha are good agents for this. Many nephrologists also add maintenance iron supplementation while patients are on ESA just to keep their iron stores continuously adequate. The goal with all this, of course, is to keep our hemoglobin between 10 and 11. If it rises above that, we hold the ESA due to an increased risk of side effects. And speaking of side effects, these would include a risk of progression of malignancy, hypertension, and stroke. That's why in patients with a prior stroke, an active cancer, or even a history of specific types of cancer, we would avoid using an ESA. And I don't believe testicular cancer is one of those malignancies that's counted, fortunately for good old Lance Armstrong over here. The last step to the management of anemia and CKD is evaluating for responsiveness to the ESA. Now, if your hemoglobin responds to the ESA and maintains at a target of 10 to 11 forever, then great, you're done. However, if the patient's hemoglobin doesn't increase to target with the ESA, there's a few things you need to check. The first is that if your hemoglobin increases, but not to the target of 10 to 11 with a stable dose of ESA, you may have to up the dose, and that's fine, you just titrate accordingly. However, if your hemoglobin doesn't respond at all in the first month, despite an appropriate dose of ESA, this is called initial hyporesponsiveness. In initial hyporesponsiveness, you should evaluate the patients for iron deficiency and any other major causes of anemia. In the CKD setting, you should pay particular attention to aluminum toxicity and severe secondary hyperparathyroidism as reasons that your bone marrow might not be responding. Remember from my slide earlier that severe secondary hyperpara can cause bone marrow fibrosis. So even if you throw a bunch of ESA at the bone marrow in this instance, it's already fibrosed and so will not respond adequately. So you'd have to treat the secondary hyperparathyroidism with calcium supplements, phosphate binders, and so on. Now, suppose you've got a patient on a stable dose of ESA, but then their hemoglobin drops while on that stable dose. You exclude other causes of anemia, check their iron levels, etc., so then you end up increasing their ESA. When you do that, their hemoglobin recovers, and you're like, great, I'm done. But then after a while, their hemoglobin drops again, so you once again exclude other causes of anemia and increase the dose of the ESA. And if you keep doing this, requiring higher ESA doses to maintain your hemoglobin at target, that's called subsequent ESA hyporesponsiveness. When you get this, just like before, you rule out other causes of anemia, but you should also consider pure red cell aplasia from antibodies against the ESA you give them. These antibodies take a couple of months to develop, and that's why the patients get subsequent hyporesponsiveness as opposed to initial hyporesponsiveness. Now, pure red cell aplasia from anti-ESA antibodies is fairly rare nowadays due to better ESA formulations. In the past, you'd get this condition with Pre-reqs, which was a brand name epoetin, just because of how Pre-reqs was prepared. And finally, a few parting words before I sign off. One is that there's these new drugs that have come out called the HIF stabilizers. What they do is, if I go back up here, they inhibit the HIF prolyl hydroxylase enzyme. So in effect, they prevent HIF breakdown and stimulate endogenous EPO production. The nice thing about these drugs is that they're oral, and they also decrease hepcidin, which allows your iron stores to be used more effectively. In some cases, in fact, people have used these drugs to replace the ESA, or even in cases of ESA hyporesponsiveness, but they're fairly new, and so not a lot of studies have come out so far. Just like the ESA, these drugs increase the risk of progression of malignancy, and they're also only studied in dialysis patients, so you can really only use them in dialysis right now. Lastly, for CKD and for end-stage renal disease, you should really avoid giving RBC transfusions. The reason is that if these patients go for transplant, the RBC transfusions they got increase their chance of alloimmunization, which makes it difficult to find a matching donor. Of course, if they really need a transfusion, they get a transfusion, but we like to avoid it in this setting. Anyway, that concludes the video. Thanks for watching.